So there's a lot of interesting research topics in MDS. I think that one of the areas of interest of mine are to understand what might be the post-transplant MDS therapy or maintenance. Is there a role for maintenance therapy? I think a lot of us are wondering, in the setting of a disease with abnormal clonal hematopoiesis and that characteristically has myelosuppression, what therapies could be given safely, are they needed, and does it ultimately change natural history? So I'm looking forward to looking at more mature data where we alter conditioning and look at post-transplant maintenance therapy. In terms of other areas, I think immunotherapies is a really great way to look. We're looking at trying to understand are there other more recent checkpoint inhibitors like CD47 or TIM3, are they active in the combination setting, the randomized trial setting? And we're hopeful that these could potentially serve as novel backbones. We're also waiting for some mature data from the Verona study. That's the azacitidine plus venetoclax or BCL2 inhibitor versus azacitidine plus placebo. We're hoping that similar to the AML disease where we saw high response rate, improved survival, that we can see the same for our patients with high-risk MDS. The preliminary data so far from the phase 1b has been really exciting, encouraging. We have demonstrated safety. Many institutions have replicated the data, showing that it's not selection bias. It is indeed possible. The regimen looks to be a really good potential new novel doublet. So a new area of research that could come from the current one is if we identify a combination approach that is safe and has improved survival, can that now serve as the new backbone? And so instead of just the new doublet, might our next question be, is there a triplet that we could then look at for our patients that could safely be given and deepen responses?